And what's useful is that you can see from this, and there are other ways of looking at the data that have come up with pretty similar conclusions, you can see where are the effects of ACT strongest and where are they not as strong. So if you start at the left, you can see that the thing that's been studied most has been relapse, rehospitalization, time in the hospital, and indeed the majority of studies, the vast majority of studies, looking at the effects of ACT on this have in fact found that it's successful in reducing relapses and rehospitalizations. And of course that was a primary focus of ACT. It continues to be. The eligibility criteria often focus on that population of people, so it's good to know it's effective in that way. And in a related fashion, the research shows that ACT is effective at stabilizing housing and decreasing homelessness. There are a number of studies that have looked at homelessness proper as the focus of ACT, and then there's other studies that have looked at stability of housing, which is partly influenced by hospitalization, but other factors as well. And no matter how you look at it, the evidence does look pretty strong that ACT is an effective way at stabilizing housing in the community. Sorry, I have to look closely at my own notes because I can't quite see this. The next one is quality of life. And what you can see is that ACT is effective at improving quality of life. And that's interesting. Now, quality of life is defined in a number of different ways by different people. But broadly speaking, there are two different ways of defining it. You can define quality of life in terms of subjective life satisfaction, and that is most often the way it's defined. And then you can define quality of life in terms of more objective indicators of functioning that are thought broadly to be considered good quality of life. So the former way, you kind of ask a person, are you satisfied with your relationships, are you satisfied with your life, and so on, and bingo, that's their quality of life, which is very similar to ratings of subjective well-being. The latter, what you do is you look at the relationships that they have, if there's reciprocity, if they have friendships, you look at the level of the independence of their functioning, you look at their role functioning, such as work and so on. Now, the quality of life that's been measured in most of the ACT studies has been subjective quality of life. And subjective quality of life is actually rather difficult to change. It's not one of these things that tends to change a lot as people function better, interestingly. And the research in the general population on subjective well-being indicates that subjective well-being is pretty stable over people's lives, even after major events happen. When they find when they look at it, for example, if something really terrible happens, you do have a reduction in subjective quality of life, but then it actually goes back up. And so it's thought to be related to temperament and other kinds of things, and hard to influence in a consistent way. But one of the things we know about quality of life is that it is very influenced by the environment in which people live. And people don't like to be homeless. They tend not to like to be in the hospital. And so my belief is that the effect of ACT on quality of life is largely driven by the reduction of relapses and rehospitalization and the stabilization of the housing, which I think are very important outcomes. That's the way I look at it. Now, if you look at client satisfaction, vast majority of clients like ACT. I know there's going to be more discussion about this in the panel, but they find it often very helpful, empowering, convenient in terms of meetings being provided in the community and things like that. And then last, in terms of pretty good effects, there are effects in terms of symptoms. You can see only about half the studies find effects in terms of symptoms, but none of the studies find that ACT worsens symptoms. And the studies that find that it improves symptoms indicate moderate levels of improvement. Now you might say, gee, that's not very strong evidence, but when you look at the number of studies that are done, if you look at this overall, that means that there's pretty strong evidence for at least a modest effect on reducing symptoms. And that's probably accounted for by improved medication management and perhaps to some extent by helping stabilize people's living conditions. Also, symptoms, it varies a lot in terms of how you measure it. So you can have self-report measures, but if you use self-report measures of symptoms, you're basically going to get a kind of a depression measure across multiple different measures. More sophisticated ways of measuring symptoms involve structured interviews and the like, and many ACT studies haven't necessarily included those. Now, there's a number of areas where, if you look at the preponderance of ACT literature, or ACT research, you don't find significant effects. One of them is in terms of social functioning or social adjustment, which refers to the quality of people's relationships with other people, the quality of their leisure and recreational activities. It also can refer to things such as self-care and independent living skills. ACT studies in their own right don't tend to find significant effects on vocational functioning. There also has not been found to be a significant effect overall on reducing time in the jail. And this is based on the broad literature on ACT. It doesn't mean that ACT doesn't have the potential to address those problem areas, but it means that ACT, as defined originally back in the 1980s and as implemented in many settings, won't in and of itself make changes or make improvements in those areas. And I'm going to get into some of that, why that might be the case and what some of the remedies might be. Now, before I go into talking a little bit more about research implications and then what all of this means in terms of modifying existing ACT programs, and some of these things are underway, I want to take a little bit of a detour and talk about fidelity. Now, what is fidelity? In a nutshell, fidelity refers to, when we're talking about it in the context of research on treatment programs, fidelity refers to the degree of adherence that a particular program has to the original intent, the procedures, the methods defined by that program. So remember that I'd said when it comes to both evaluating treatments as well as evidence-based practices, a practice is an evidence-based practice if it's been standardized in some way, and then if that standardized version of the practice has been shown to improve outcomes in controlled research. So what fidelity is it's a way of measuring whether we know that the program's been standardized, because you need to have some kind of a manual or something like that, or a set of procedures or principles. A fidelity measure is a way of actually quantifying, measuring systematically how close a particular service is, or how close an intervention is to the original definition of the model. And all research evaluating different interventions for any psychiatric illnesses have to have some way of evaluating how close the clinician is, or the group of clinicians or case managers are to the original principles of the program. And so fidelity scales are how that are done. Now, I should say that there are lots of different approaches and ways of developing and implementing or using fidelity scales. So there's no one way of doing it, and part of it depends on the nature of the service that's being evaluated. There are a series of fidelity scales that were developed as part of the SAMHSA initiative that we were a part of in developing evidence-based practices. And so if you go to the SAMHSA website and you look under evidence-based practices, what you'll find is a number of different toolkits or standardized guidelines for implementing particular rehabilitation practices. And then for each of the different toolkits, there's also a standardized fidelity assessment. So let me tell you a little bit about the fidelity assessment that has been used often to evaluate fidelity of assertive community treatment teams. Just checking to make sure. The scale that was developed eventually and modified for the SAMHSA toolkit project was first developed at Dartmouth in the 1990s. First version of it was called the Dartmouth Assertive Community Treatment Scale. And the idea of it was to obtain information from a variety of sources, including observation, including records, including interviews with both people at the level of case management, but also at the level of program leaders and consumers, about the actual practice of assertive community treatment. And then the way it's actually done is that there's a day-long visit, there's 2 trained assessors. As I say, they use multiple sources of information, they review records, and the like. And I won't go into a lot of detail. At the site visit, they'll get together, have some meetings with consumers, with some of the case managers, the program leaders, and they kind of find out what happens, where the service is provided, what happens during those services, and so on. And then there's a whole series of criteria. I actually thought of putting them in the PowerPoint, but then I thought I would save you from that. For example, what percentage of services are provided in the community? Are the caseloads shared or not? Are the majority of services provided directly by the team or not?